Asan Yusuf sir from General Surgery Department, SNHRC, who will share his expertise on from medication to scalpel, revisiting acid suppression therapy. Where do we stand today?
Good morning, one and all. Good morning to all judges and faculties, delegates on and off the dais. To begin with, where we stand here, in terms of acid suppression therapy, all the way from medication to scalpel, medication to surgery, actually, where do we stand in today's modern era? Initially, this acid suppression therapy is the cornerstone of GERD treatment, and that's why it ranges all the way from pharmacological therapy to surgical intervention. And surgical intervention has revolutionized, and it has included all these minimal invasive techniques and endoscopic techniques for GERD anti-reflex surgeries. And there are a lot of things into consideration for GERD, a lot of determinants. We got all these offensive determinants, offensive factors, and defensive factors. Like in terms of offensive factors, we have all this acid, bile, and pepsin. In terms of defensive factors, we get this LES sphincter tone and musculature structures. And determination of esophageal gastric junction, it depends based purely on intrinsic LES pressure and intra-abdominal length of the esophagus, and extrinsic compression of the LES by the crural diaphragm. All these components are very important. And apart from this, we have a lot of these food ingredients we have day in and day out, which ultimately ends up in decreasing the LES pressure. So it's very important to know about all these food habits, because we have all these food habits. We have this as an daily intake. We need to regulate this in order to achieve the lifestyle modification. And we see here in the list there is no food ingredients that increases the LES. Eventually, all the food ingredients that will only decrease lower esophageal sphincter. And the evolution of acid suppression therapy, that was beautifully explained by Dr. Kishore sir. That's the elegance of epitome. We need to know the history about how it got revolutionized, how it got evolved all the way from antacid, and then we got all these PPIs. Now we are going towards the PCABs, and we got the very lucid perception of the PCABs. Thanks sir, thanks Arun sir for that crisp perception of interpretation of all these PCABs. And we have all these recently evolving antihistamines and proton pump inhibitors. We got all these tenetoprozole and levolotidine, and they are still coming to the market, and certain drugs have already come. And I'm going to talk about all this surgical intervention, this endoscopic intervention and surgical intervention. And coming to the limitation of medical therapy, why there are limitations? Because dimetazine, we see a lot of people having a lot of PPIs, and they end up having all this hypomagnesemia and bone diseases and even vitamin B12 deficiency. And to overcome all these things, we have certain criteria: who are the patients, who are the candidates who have to undergo all this anti-reflex surgery. So we have a list of patients who can go for this anti-reflex surgeries. And very popular among those people are those who are refractory to the PPI treatment and intolerant to the PPIs, and inability to there's no compliance with the PPIs, and these are the candidates whom we subject to the surgeries. And remember, we are not rapacious about the surgery, and the surgery itself is very onerous, and it's not that easy. So I choose my words very carefully lest they are misconstrued, because I'm not telling that I'm going towards the surgery. Surgery is not the last. Surgery is the last resort, but it's not the definite resort. The patient selection is a very important one as far as GRD treatment is concerned. When comparing medication with surgery, medication is very non-invasive, widely available, and very least expensive. In case of surgery, it is very expensive one, and very demanding, and it needs expert experience and expert opinions. And coming to the surgery, we have all this endoscopic surgery like STRETA, TIF, transoral incisionless fundoplication, and MUSE and ARMs, and we'll be discussing entirely about each and every entity. And in surgical, we have this anti-reflex surgery and even the gastric bypass. So you see here, a lot of people, they have the tendency to take PPIs regardless of over the counter or through the doctor. And there are some people, they go for the surgery, and there is a gap between the surgical treatment and the medical treatment, and those are the people they don't get resolved by the PPS, and that is the gap. They are almost 25 to 30%. And yeah, so to whom we should give all this Nissan fundoplication, I will be seeing in the subsequent slides. And these surgical steps will be like, we have Nissan fundoplication, and that is a full wrap, and there are some partial wrap techniques. And lastly will be the augmentation of the lower esophageal sphincters. And once upon a time, we had one instrument. So this instrument is called angel check. It is no more in use now. So it had its use once upon a time. It was very much similar to LAGP and made of all these silicon tubes, and it also has this Dacron in it. And the only problem here was the poor durability of the instrument, so it was discontinued. And it's the basis for the LAGB actually. And based on this only, we are using LAGB now. And this instrument is not practiced nowadays. And the history, Nissan fundoplication, the man who operated on Albert Einstein, and little bit of other surgical options. We have all this posterior wrap and full wrap, that is tope and door techniques. And is anti-reflex surgery is a magical treatment for reflex or not? We'll come to know. The very key points are wrong patient selection will land up in very much troublesome for the patient, and very good surgery even in the very severe cases won't help. So proper patient selection is an important factor in terms of anti-reflex surgery, and that's why we need SAG guidelines when to go for surgery and when not to go for surgery. In terms of adults, we have whenever the medicine or surgery is compared. In terms of goal, if we need to go for chronic and refractory GERD, it is better to go for surgery than the medicine. And in case of whether to go for partial or complete wrap or fundoplication, it is better to go for complete fundoplication rather than the partial wrap. And in case of pediatric population, they differ a lot. They say that the study is not that much sufficient to comment on whether they are needed to subject for all these fundoplication techniques. And last, this thing, both robotics and laparoscopy are equal in efficacy. The only thing is the cost and the expensive this one of robotics and laparoscopy. And in terms of distension of the stomach, and that's how the lower esophagus is taken away by the cardia whenever the stomach gets bloated, and that's the mechanism. So in order to keep the LES place it in the same place, we do all these types of intervention, both in terms of laparoscopy and minimal invasive or through endoscopy. So initially we have this Nissan fundoplication through 5-port trocar, 5-port technique. We retract the liver, and then we go posterior to the esophagus, and then we wrap the fundus. And it's a very beautiful sign for a surgeon to see. It's a shoeless sign, and we wrap the fundus from posteriorly, and then we suture it to the opposite side so that it gets wrapped tightly. And this placement of sutures for the fundoplication, and ultimately we see a finger can be passed. That's how we check. Nowadays we got this lap-assisted Nissan fundoplication, and there are some modification to the Nissan fundoplication where they divided earlier in those days they divided a short gastric artery. Now they want to preserve the short gastric artery, so that's where we come through this Rossetti-Hill modification of a Nissan fundoplication. And tope is a posterior wrap, unlike Nissan fundoplication, where there is a 360-degree wrap. Here it is only a 270-degree wrap. And Hill's esophagogastropexy is, you are plicating the lesser curvature with the median ergoid ligament, so it's a very good option. And some of the other alternative approaches, and those that are abandoned or not in practice, are Belsay 4-mark surgeries and other Hill repair 90-degree lesser curvature plication. And this is entire wrap of the fundus around the esophagus, so that it helps in tightening the lower esophageal sphincter. And I'm very much fond about this Coley's gastroplasty. I'm not lucky enough to see all this kind of surgery. It was surgery once upon a time. In this generation, in our generation, we are not able to see all this kind of Coley's gastroplasty. It was a wonderful innovation where they thought like to increase the esophagus intra-abdominally. They wanted to create the neo-esophagus. So they came up with this beautiful idea, but unfortunately, the neo-esophagus did not coordinate with the peristalsis of the esophagus. So this procedure is not done that much nowadays. And this is a final view of the endoscopic fundoplication procedure, and that's how it is. To sum up all this fundoplication, we have Watson, that is anterior 120-degree flap rotation, and door is 180 degree of flap rotation, and tope is posterior wrap rotation, and Nissen fundoplication is entire 360-degree wrap. And some of the complication of fundoplication, commonly we have the first image is disrupted wrap, and second is the sliding hernia with the wrap in the abdomen, and third is the slipped fundoplication onto proximal stomach, and the last is the intrathoracic migration. These are the very common complication we go through whenever we do fundoplication. These are the laparoscopic approaches, and apart from this, we'll go through all these latest and novel techniques that are coming up with to tackle all this GRD. We have all this Linux and everything. And Linux is actually, it's a necklace of magnetic beads that is placed through laparoscopically in the lower esophageal segment, so that it wraps tightly against esophagus. And you can think that these tight magnets can compress the esophagus, but it's not the thing. Whenever the intraluminal pressure goes up, automatically it overcomes the magnetic pressure. So ultimately it's a SS and a win-win situation for the patient. And the only limitation with the Linux is the compatibility with the MRI. So that's an issue with Linux. You see this beautiful wrapping of lower esophagus with a magnet. And this Medicus ultrasonic surgical endostapler, it's a very beautiful technique where the where the endoscopy goes retroflexed against the cardia, and then there are certain probes in it, and that senses it, and it gives we can fire the stapler so that the lower esophagus goes for tight thing. And then we have this transoral incision-less fundoplication, and it's a very beautiful one. It's a linear stapler that goes in a 360-degree manner, and then it when you fire it, and it ends up in a tight wrap. And this one, and the mucosal resection, that is anti-reflex mucosal surgery. This was popularly done in Japan, and they use this EMD and ESD technique basically. But the problem was they had to have a lot of long RCTs with a long follow-up. So they are on a way to go for it, but the results are very good. But at the end of 3 years, you can see initially they have taken almost 2 centimeter of gastric mucosa and 1 centimeter of esophageal mucosa, and it ends up in 3 years to get the very tight sphincter. And ARMS is still an emerging one. FDA has not approved it. A lot of trials are going under to pass through the FDA. And the Strata procedure, we have this 4-channel radio frequency in it, and then we have balloon catheter that goes into the esophagus, and ultimately it gives some sort of heat energy not exceeding 85 degrees of Celsius, and it gives around the esophagus. And one may think that a lot of heat energy may end up in stricture of the esophagus. That's not the case here. And they have given all this sildenafil before Strata, and it has very much given the good response. That means that there is no connection, there is no correlation between the stricture and the Strata post Strata procedure. So Strata ultimately is similar to that of more of a laser in the piles. So almost we are giving a little bit of heat, but instead of going in for stricture, it augments the LES, and ultimately it ends up in tight LES, and yeah, that's how it works. And this thing, apart from this, we have all this endoscopic bulking technique. We use all entire bipolar augmentation and PMMA and gatekeeper reflex. But these things are cleared in the Europe CE, but it is not cleared in the FDA, still in the workup. And gatekeeper, basically it was similar to that of laryngoplasty. All this we have like type 1, type 2, type 3, type 4. Similar to that, we are going to inject just like Teflon there. Here they are injecting all this material into the lower esophageal sphincter so that it gets bulked off, and then that allows tight sphincter. It won't cause a reflex to pass into the esophagus. And finally, this one is a neurostimulator. That is, we have these 2 electrodes kept in the muscularis propria, and some bipolars are connected. And continuously, we need to stimulate the lower esophageal sphincter, and a little bit of cumbersome procedure. But still, yeah, it is not FDA approved, but still on a theoretical basis, they are considering it. And some sort of enterics procedure, we have this injection of 8% ethylene vinyl alcohol, and still it's a kind of a bulking procedure for the LES. And some of the things, some take-home points where, patients with Barrett's esophagus who undergo anti-reflux surgery do not seem to have low risk of esophageal adenocarcinoma than those with anti-reflux medication. And the site, and based on the current meta-analysis, we conclude that recurrent GRD can be safely and effectively treated with ECSF as an endoscopic procedure. And to sum up, the most commonly performed fundoplication is Nissen fundoplication, and rarely performed is Watson and Belsey Mark IV, and most commonly performed partial fundoplication is the Dor fundoplication and Tope. So to support certain articles in favor of all these surgeries, we have this Lotus trial where there are large RCD fundoplication and isomeprazole equally effective in long term, and doesn't mean that PPIs have got upper hand than surgery. Sometimes it's on the other way around. It happens, so much studies going behind that. And also in the University of York, there we have surgical management more effective short to medium term, and long term needs more study. Basically for short term it's a very good option, and long term outcomes of surgical therapy. So Lund et al, what they have seen is into the post-operative side effects reported, but very durable overall. And meta-analysis on the fundoplication. In this meta-analysis, we have fundoplication to reduce reflex symptoms than the PPIs. So it's accepted one overall. And moreover, again I said like earlier, it was it's all about the patient selection, the procedure selection, and the performance selection of the procedure. Ultimately, that favors the surgery. Fundoplication is too much surgery for early GRD. It can be done for severe GRD. For early GRD, it's definitely too much of surgery, and that's why I'm choosing my words very carefully, lest they are misconstrued. So we need to choose the patient very carefully whether to go, who are the candidates for surgery and who are the candidates for PPIs. And again, it's a beautiful saying, I got this. We as surgeons or other medical professionals have a tendency to blame the operation when we should blame how the operation was done. A good operation done badly will lead to poor results. And actually, I'm a big fan of history. History is a very important thing. It's a lifeline for us. And Nissen, who operated on Albert Einstein, who was suffering from abdominal aortic aneurysm, he came up with a new idea, to fibrose that aortic aneurysm. He used cellophane tape, and that ended up actually in good result. And that's the innovation. That's how we go with it. And that's the point where he started all this wrapping technique for Nissen fundoplication. Yeah, thank you.
Thank you for the elaborate lecture on surgical procedures. Dr. Mian is with us. He is a very famous surgeon from CMC. So I would like to request him to share his experience.
Thanks so much. You have highlighted the important points along with the newer advances as well. I think the most crucial thing is, as you said, patient selection, because this is an indication, this is an operation where it's a lifestyle thing, and most patients, if you need to select them properly, you mentioned a few things, but in practice, basically the indications are, one is if they respond, actually if the patient respond poorly to PPIs, then they're actually not good candidates, because they should respond well to PPIs. That is number one. Number two is if they have some complications like Barrett's, or if they have esophagitis, that is number two. And number three is if they have some anatomical problem like a large hiatus hernia, paraesophageal hernia, those are good indications for surgery. And of course, number four is a young patient who needs to be on lifelong PPI. So that again is, so there are four indications for surgery, and proper patient selection is, I think, crucial, whatever good operation that you do. So that is crucial. And one other thing that I want to just highlight here is what other investigations apart from endoscopy do you need to do? For example, do you need to do a pH study in all patients? Do you need to do a manometry in all patients? So in our clinical practice, basically, a good endoscopy is important. If there is an anatomical problem on endoscopy, you really don't need a pH study. However, if you have a normal endoscopy and the patient has got reflux, then this patient requires a pH study. That's number one. And number two, it is always good practice if you have a manometry to do a manometry prior to surgery in all patients, regardless, because I think this can be associated with motility disorders, and therefore a manometry is a must. pH study is optional if there is a normal endoscopy. Any questions from the audience? Dr. Rajavelu is there. Any questions, comments? Okay, thank you very much.